A 38 years old lady is troubled by lymphedema that occur following block dissection of the groin due to malignant melanoma. So due to malignant melanoma, the groin lymph node dissection was done many years previously. Despite therapy with compression bandage, she has persistent lower leg swelling, impairing her activity of daily living. She has no evidence of the recurrent malignancy. Lymphangiocintigraphy demonstrates occlusion of the groin lymphatics. However, the distal lymphatic channel appears healthy, which is the following option could be considered. That means in this patient, what happened in this patient? Suppose this is the leg or groin area. So in this groin area, for the malignant melanoma, the lymphatic lymph node were dissected and removed, but after many years they develop lymphedema. That means there is the lymphedema, but the distal lymphatic channel is okay. So distal lymphatic channel okay, that means in the distal area there is patent, but when it coming to the groin, it is not possible to drain due to damage of this area lymphatic channel. So what should we do? This distal is patent, so if we can connect with proximally or we can bypass with other route, in this condition the problem is solved. So let's see the options. The options is lymphovenous anastomosis, Homan's procedure, Charles procedure, loop diuretics therapy, long-term amputation. So first of all, let's see the different causes of the lymphedema. There are different causes of the lymphedema. It may be primary, it may be secondary. Why it is secondary? When there is a definitive cause present, such as the bacterial, fungal, parasitic infection, lymphatic malignancy, radiotherapy to the lymph node, surgical resection of the lymph node, DVT, thrombophlebitis. And our patient, it is the surgical resection of the lymph node due to malignant melanoma. And some primary cause, that means it is the congenital, such as the Milroy, Mays and Tarda. And here the age is very important. The age, when it is less than 1 year, then Milroy. When 1 to 35 years, it is Mays, and when more than 35 years, it is the Tarda. Now see the lymphovascular anastomosis. Identifiable lymphatics are anastomosed to the subdermal venules, usually indicated 2% of the patient with proximal lymphatic obstruction with normal distal lymphatics. So when there is normal distal lymphatics and lymphatic channel with proximal lymphatic obstruction, in this condition what we can do? We can go for the lymphovenous anastomosis. Here we can see this is a procedure of the lymphovenous anastomosis. Here we can see this white is this whitish or the grayish or yellowish area. This is the lymphatic channel, and this is the vein. So this lymphatic vessel is connected with this vein, and finally what occurs here? We can see this is a vein and this is the lymphatic channel. So lymphatic channel connected to the vein, and this, as the distal part is completely okay, so it goes to the vein and enter the systemic circulation. Again, here we can see this is the another. Here we can see this is the anastomosing area, this is the anastomosing area, and here we can see this is the different type of the lymphatics. They are connected with the superficial subdermal vein. So what we should go for? We should go for the lymphovenous anastomosis, because our distal, we can see distal lymphatic system is okay. So when we anastomose the vessel with the lymphatic vessel with the vein, it is possible to drain.